wanted to arm you with some information about what these terms mean, what this idea of child is, what some of the other families, if you're on the face page, which I'm not, I just informed consent. I don't lurk, I don't get on there, so you guys have your own space, but there are families on there who are going to have these different diagnoses. Some of them are here. And this is a big umbrella, and I'm going to explain the philosophy for that. So I'm going to tell you a little bit about these different disorders so that you can relate to other families, you can understand it, and you can advocate for the foundation. So just starting, and I almost always use this slide from the very beginning because it's helpful, and that is that Children's Interstitial and Diffuse Lung Disease is our acronym, CHILD, to distinguish it that it is a pediatric disease. And it's not a specific diagnosis. As you all know in this room, it's made up of a bunch of different diverse and rare conditions that have a lot of morbidity, which means you have a lot of things you have to deal with, your oxygen, feeding, and unfortunately in some of the conditions that we see as physicians, mortality. Now that may seem like a no-brainer to you, but I can tell you 10 years ago the diagnosis just used to be ILD. And that was it, and people stopped. And it may be that some of the places you've come from, it's still that way. But it's very important to drill down and understand what your child has. And these disorders are described as rare, and they are rare, but as physicians in the network, because we have a lot of these diseases under our umbrella, we actually are busy with these different conditions full time. So for us, it's actually much more common as a group. And these disorders are frequently under-recognized. I think all of your stories may highlight that condition. And then ultimately, you may start by seeing a neonatologist, but if you have a significant amount of problems, you're coming to a pediatric pulmonologist. And so we have pulmonologists on our network, neonatologists, an imager or a radiologist will likely see your films, and if you go to a lung biopsy, a pathologist. So we have all of those people included in our network, which we're quite proud of. So I'm not going to tell you anything you don't know. And in fact, I'm going to, if you don't mind, have a show of hands. So one of the studies we did, we looked at what are the signs and symptoms, and we always show this slide because we want people to understand that these conditions, these kids are pretty sick. And the one thing about the foundation is, and you guys are going to know, and I'm going to demonstrate that, are that kids present with similar symptoms. So how many of your kids presented with low oxygen at some point in time? Okay. How many tachypneas, fast breathing? Retractions, just a second. See, so I like that. We're consistent. Now, some of the other conditions, how many people had gastroesophageal reflux? Failure to thrive. Crackles. Cough. Okay, a little different group. So because you see there's a divide. Normal when you listen to their chest. Couple. And then wheezing. Okay, couple, not too many. But so you can see there's similarities, especially in the top group, about how you present. And so as physicians, this is what we see. We start with this. And that's been one of the biases for the foundation is we needed to start with how these kids look to come in to get people to recognize this and drill down that when they see this and don't have an answer, it's going to be one of these conditions. So Dr. Fan did some work in Houston with one of his fellows. Now this is a little dated, but it helped us. The doctors said, well, we know it when we see it. Well, that's not quite good enough. So we tried to define it a little bit more. So we came up with this criterion that you all just demonstrated. So if the patient or the child coming in presents with any three of the four, in the absence of another diagnosis that defines the condition, we want doctors to start to think about this. So respiratory symptoms, cough, fast breathing, exercise intolerance, you all demonstrated that. Respiratory signs, retractions, clubbing, sounds in the chest, low oxygen, and then findings on the chest films or the CT scans. Now, the caveat for this is that sometimes conditions, if you're born prematurely, that may not be the answer because, in fact, it's out of proportion, so you have another one of these conditions. So I'm giving you some of the slides that we show at our national meetings because as you leave here, you're also the experts with us now in knowing how we talk about this condition. So this is child syndrome. These kids, when we see these kids in the network, we're going to start to think about, do they have one of the child conditions? And many of you know this. This has been the standard workup that many children have to get when they have a child syndrome condition. And most of the kids in this room got this type of workup. So how many of you got a high-resolution CT scan? How many of you had infant pulmonary function? Some of you. Oh, pretty good number. Bronchoscopies, genetic testing, lung biopsy. Well, I also have another slide that I'll show in another one of my talks. Do you know how much that costs? You probably do. We don't. Actually, you do. This side doesn't as much. Okay, and my data was dated because my slide's old. This workup is over $50,000 or more. Is that correct? Is it an underestimate?
It's an
Underestimate. Okay, so not only is it stressful, and not only is it not perfect, because some of you still don't have a diagnosis, right? It's expensive, and we have to do a lot better. And that's what this side of the room is very focused on, doing better for you, your children, and other children who come in with these conditions. So that's chILD syndrome. And this was a landmark activity for us that ended in a paper that became very important for our field. And how many of you guys were involved in this paper? Okay, many people in this room were involved. And this paper was important because it included all those different types of doctors. And we got together and we said, these kids don't act like the adults with these conditions, especially the young kids. Okay, knee height, nobody even knew what that was, and we don't see that in adults. So some of the conditions don't act like that. So this paper became very important. Megan Dish is in the room. She worked with Claire Langston, and they had this idea about how they could categorize these lung samples, these biopsies. And we started with biopsies because that really was the gold standard in both the adult world and the pediatric world. When you don't know what's happening, you need to see the lung tissue to get an idea what's going on. So this classification scheme where we had these disorders more prevalent in infancy, this was really a new concept, and I'm going to talk about some of those groups. And then other groups, disorders that masqueraded, pulmonary vascular problems, lymphatic problems, we could classify that way. Kids who were immunocompromised, so their immune systems were not right, either because they had immunodeficiency or because we gave them medications to make them that way. Kids with systemic disorders, I'm going to talk about a few of those and show you. And then kids who were normal but had environmental insults, infections that gave them conditions that we see. All these kids can come in with chILD syndrome, okay? And they can happen from newborns all the way through adolescence. So this is how we began to think. And we became very focused on these kids under 2. But our network and who we think about under the chILD umbrella encompasses this whole area. So these are the chILD disorders. I think many in the group, there's a lot published. Well, a lot is relative, but there is more published on these disorders in the literature for children. But these are the ones I'm going to just touch on because they're the ones that you're more likely to hear about from other families. And these are the conditions we see sometimes in younger children more often, and these are the conditions sometimes we see in older children, so adolescents. So there is a little age paradigm, and I'm going to show you that. So when I talked about systemic disease, we're talking about collagen vascular disease. Adolescents can get lupus and these other connective collagen vascular diseases, and they get ILD or pulmonary hemorrhage, which is the next area. And autoimmune diseases, even inflammatory bowel disease can have a component that can be in their lung because sometimes that can attack their lung. And then I've mentioned that immune deficiencies can give you lung disease. So this is a big umbrella. But all of these kids to us come in with these chILD-type diseases. This is just a graphic showing you, kind of looking at this in a pie chart. So this is our under 2 group. And what I want you to notice is these from the asterisks up, and in this group are the ones that are more commonly present that we see under 2. And notice the difference in the pie chart from those from 2 to 18. This little group is tiny, this little group is big. That was really the contribution to the literature, and that's why many of you have young children are in that group. But it doesn't mean that we don't see kids who are immunocompromised, and they can come in and we can see them early, or kids that have been impacted by an infection. We can. But when we're older, notice the immune-compromised group here and the systemic group, which is more of the lupus, the collagen vascular, gets bigger, and these conditions get smaller. Now, your kids grow up, but they tend not to be diagnosed in that age. Okay? I'm back to here. So Growth abnormalities. So I just want to talk about this because another thing that makes this important to be under the same umbrella is that our kids' lungs are developing. They're growing. So all of these diseases are happening on the backdrop of how your lungs should be growing and getting more air sacs and better and bigger lungs as you grow. They need to keep up. So the lung development component also impacts children as they grow, and we began to notice in that one review that there were groups of children who had signs and symptoms of chILD, all those things you raised your hands about, that hadn't been diagnosed with this, and yet this was the primary condition. And when we talk about this, what we mean is that the air sacs in the lung are too big, okay, instead of small and tiny, and I'll show you pictures of that. And there was a strong association with congenital heart disease. So this changed how we thought about congenital heart disease patients, Down syndrome, and then prematurity. We in the pulmonary world always knew that that was a component, so that wasn't so much of a surprise. But these kids were out of proportion in how sick they were. And now 34% of this group, though, can die. They can have mortality if it's severe enough. And some of them had this patchy pig, and I'll talk about that. So here's a look at how that looked. This is in the figure A, a child with a normal lung biopsy. And hopefully what you can see are their tiny little air spaces. And the air space is where all the action is at the end. Okay, the air tubes have to take everything through there and clear mucus out. But the air spaces are where the oxygen goes in, the carbon dioxide comes out. And that needs to have a very thin wall for that to be really efficient. And the more air sacs there are, the more exchange areas you have. So that's good. You want that. But look at the one with the congenital heart disease. This is taken at the same magnification. That child had pretty significant lung disease. Pulmonary stenosis is a type, and she also had other types of congenital heart disease. This is a Down syndrome child, and you can see that the alveolar spaces are more abnormal on the outside, or the outer part of the lung. This child also had pulmonary hypertension or high blood pressure in the lung. And then finally, this is a child who was born prematurely. So if you're born prematurely, you don't have as many of these alveolar spaces, and there's a lot of work, and some of the scientists who were in yesterday are talking about this lung growth and how the lung should grow normally. So these are still too tiny, so any disease you have on top of that really makes a difference because you're starting with lower air sacs. And then we're showing in this case that there's some of this pulmonary interstitial glycogenosis right next to it, and sometimes that makes these kids seem sicker. So speaking of pulmonary interstitial glycogenosis, did anybody have that diagnosis? Okay. Usually this comes in the children in the neonatal intensive care unit. We don't see it past 8 months of age. It almost always complicates a newborn course. The neonatologist will see these kids. Unfortunately, the diagnosis has to come by a lung biopsy. But it's associated with congenital heart disease and prematurity is where we see it. And the oxygen's out of proportion. That air space has that thickness to it, and the oxygen just can't get out as well. And x-rays really don't diagnose it, as I said. And this is a picture of that lung. So if you remember the normal lung, now, instead of being very, very thin, now it's very thick. And the oxygen has to go from here into a capillary in there. And so it's very hard to get oxygen in. And these children have problems with oxygen. Okay? And it makes any condition that they have, a growth disorder, worse. So we see this as a complication and sometimes get asked in our network about this. And this publication that we worked on together was really one of the first times it had been reported before, but we reported it again in more children, and more some of the doctors in the network and in the neonatal intensive care unit are recognizing this condition. The good news is after 8 months, it seems to go away. So now I'm going to talk about NEHI. I know there are many in the room with neuroendocrine cell hyperplasia, and this has been an interest of ours for many years in Colorado. Dr. Fan, Dr. Langston, and I teamed up to look at this series of children that we were seeing in Colorado who came in looking like what you know they look like, which is crackling, breathing fast, and retracting, and we'd say, boy, you got ILD, because then that's what we called it. And we said, you need a lung biopsy, and we get a lung biopsy, and they'd come back, well, it was kind of normal. And both the family and ourselves as physicians were very unsatisfied with that, because we'd say, this is not normal, looking back at the child. So Dr. Fan took these slides together down to Dr. Langston and said, there's got to be something there. And she looked at this, and when you look at a lot of things at once, sometimes you see patterns. And she began to recognize these clear cells, which were ultimately proven to be neuroendocrine cells by bombesin staining. And that really became the basis for the original way we diagnosed the patients with these biopsies, is the bombesin staining. Now, we didn't know, and we still don't know today, whether these cells are active in the disease or whether they're markers of the disease, but they're there. And that became the recognition point that these children existed. And the other thing is there wasn't anything else on the pathology there. There wasn't a lot of other diseases there, so it was in isolation. And that became the way we thought about it. So you've seen some of these slides in different places if you were in some of the talks yesterday. So this is a staining for that bombesin protein, and this is an airway. And normally, these cells are very involved as the lung's developing. They're very involved in how the airway and the lung branches, so they're important in lung development. You need them. But after 6 months of age, and even after you're born, they start to go away and disappear. So you shouldn't have too many of them. So there were too many, and we compared them to normal controls. So these cells are in the airway and the lungs, and then there are a group of these cells that they call neuroendocrine bodies that can be out in the lung tissue. And the pathologists count these up and came up with a scoring system. And so there's no other pathology that we see on the biopsy. And they're usually diagnosed under 2 years of age. Their CTs can be unique. That was another thing the network was able to show, which was very helpful in getting a chance to move away from biopsies. Their lungs are air-trapped. If you've had pulmonary functions, that's what we're looking for, to have a consistent diagnosis. And many of you have to be treated, and the duration of your oxygen is very variable. And we have seen that this runs in families. Now, this is where we are. We've made a great deal of headway since 2005 when this has been published. But I don't need to tell you guys that despite all this headway, we really don't understand the mechanism of this disease. We're seeing variations of this disease now. And now the physicians, so this seemed real simple. It's not simple, because now we have those that have the bombesin diagnosis but have these variations. And then have the CT that looks right and the clinical course, and then their pathology looks different. So the challenge for the network, and I'm going to say that what's really important, is we need a lot of these kids in our database to understand these variations. We recognize classics, but those that aren't classic, outside the classic range, we need to recognize them too. So the other group is surfactant. Now, these surfactant mutations. Surfactant is very important in the lung. It's critical. It's a lubricant of the lung, and it lines the lung right at the air liquid interface. So this tissue here and the air, and then there's this liquid that lines the lung, and it's a surfactant. So it's a lubricant of the lung, and it helps hold the lung open. Without it, you're not able to survive, and it's when it's dysfunctional, you're not in very good shape. Sorry. It's made up of lipid, a certain type of lipid solution, and these proteins that make it function right and to layer right. Now, premature babies, let me finish this and you can ask a question. Premature babies don't make surfactant initially because the cells that make the surfactant aren't turned on yet. And early on, the neonatologists and the researchers found that if they could give steroids, that helped the cells turn on to make the surfactant faster. And so sometimes people are going to go into premature labor. They're giving you steroids to try and have the system turn on to make these surfactant systems so that the child can breathe better in the newborn course. Now, the thing that makes this different, and we get asked this question a lot, was, well, so they give them surfactant too. So when they're born, a lot of babies get surfactant, again, to try and help them overcome this lack of lubricant so the lungs can function better. So they say, well, why can't you just do this in some of these mutations? Well, the problem is the surfactant's not normal, but the cells that make it aren't normal. So you're not just waiting for them to develop and turn on. They're not normal. So just giving the surfactant again and again is not a solution. In fact, some of the systems to clear it are messed up too, and it can make children potentially worse. So the cells in these mutations aren't normal, so it's different than prematurity, but I wanted to explain that to you because we get that question a lot. Did I answer your question? Almost? Good. Give it to me.
My daughter's lungs, that you were saying, has more like it's supposed to be a spongy material.
Yeah.
And hers is more like a liver texture.
Mm-hmm.
And I'm wondering if that's just there's no surfactant in there much at all. I mean, they're giving her steroids, but I'm just kind of curious.
So,
Protect the capillaries, is what you're saying?
so if you're, sometimes physicians talk about spongy, or people will say it's like a spongy material. What that means is, if you looked at some of these pictures, the lungs are very fine network, very thin airways, and they start to say it looks like liver when those air spaces get really thick, and all of a sudden they fill up with things, and you can't even recognize the air spaces, and people will start to say it's spongy. It's not this light, fluffy lung. So we doctors use things like that, and it becomes very, but conceptually, but that's usually what physicians are saying, is that the lung is not this nice network of air sacs and air tubes anymore. It's filled up with these other substances, and their air sacs are really either gone, or the lining of the air sac is really thick. And you're right, you can't get oxygen in, so your child needs oxygen.
So did I miss it, or did they say they can measure that?
You can measure oxygen of the surfactant. Oh, that's a good question. So we don't measure levels of surfactant in the airway, and we don't do it in the blood. But that's a very good question, as we talk a little bit later about how we can measure proteins in the blood that are surfactant related that may be hints that people have a disease. So hold that thought to later today. That's exactly right about how we're thinking from a research perspective. Okay? So the surfactant abnormalities, and if you're on the Facebook, you're going to hear from these kids and their families. So these are genetic abnormalities. They're born with that. There's a specialized cell in the lung that makes it, the type 2 cell, and it's unhappy. It doesn't make good surfactant, and the cell is unhappy because it's not functioning right. And these children have gene abnormalities that can impact even other diseases. So even if they have a mild disorder or one gene that may not cause the full mutation, it may affect disease as adults. So we think this is very important. Genetic testing is usually the first line now because of some of the people in this room that you're going to hear from and how they've discovered genes. Genetic testing now can be done if the child is well enough to wait before a lung biopsy. So we're trying to put the pathologists out of business, Dr. Bishop, because that would be better for us all. But if you can get testing, that can avoid it. Sometimes we can't, depending upon situations. And then the known gene abnormalities are listed here. And this is just a little graphic showing where these different disorders happen. And it's not important to know exactly what the physiology is, but these disorders happen, these mutations in the type 2 cell in different areas and can cause subtly different diseases. And this cartoon is courtesy of Dr. Nogi, and I show it again and again because it's very nicely done. So this is just where all the disorders happen, but it impacts the system and the lungs get unhappy. So the other condition, and I know there are some people in this room who have this bronchiolitis obliterans. Now this, we're moving out from the air sacs now to the air tubes. And so this disorder causes scarring in the air tubes. And this is a picture of that. So this should be a normal airway, okay? And it should be about this size, but now it has scarring, and so that the air moving through that airway struggles to, it can get in a little better, but when it tries to get out, it gets trapped. And when these children get viruses and this gets more swollen and full of mucus, they can struggle more. So they have a lot of these exacerbations. So it can be harder at baseline, and when they get cold, it's very difficult. And you can see there's already a little stuff in there because these airways don't clear out mucus so well. So it's not only that they get air trapped in, but they have trouble with mucus. And these narrowings or obliterated airways can be caused by infection, post-infection causes, as well as these autoimmune causes, whether it be, we see this post-lung transplant, we see this post-bone marrow transplant, sometimes a skin reaction called Stevens-Johnson, we see it, and there can be other conditions. So environmental causes can cause this with infections, or autoimmune causes can cause this. But it's a significant component, and in the pediatric under 2 and the 2 to 18, this group was 30%, same, both. So we see it throughout childhood. And I know some of you are here with this. So we have to think. They look the same, but we kind of have to think differently about how to get to treatment because your treatment will look different.
How do they find that? How do they find that scar tissue?
Well, if we do a lung biopsy, you can find it, but we get a strong suggestion of it based on the CT scan and lung functions because they trap air in and has a very specific look on CT scan. So these children don't always have to go to lung biopsy. That's good because the clinical group here has made great progress in recognizing these children. And then there's a group who has immune dysfunction or immunodeficiencies. And when your immune system's not right, the lung is connected to the outside. We don't think of it that way, but it is. And so if you have an immune deficiency, you can breathe in particles, you can breathe in viruses, and children who have immune problems can end up with these different types of lung disease and these big immune responses in the lungs. And we see this also can be a difficult problem. And then there were a couple posters, if you walked around in our poster session, about kids who have pulmonary hemorrhage. They're bleeding into their lung. They're not bleeding anywhere else, but they're bleeding into their lung. And their x-rays can look hazy, and when you get their, oops, it's very sensitive. And when you get their CAT scan, you can see these patchy, that's blood. And when we do a biopsy, you can see all this blood-filled staining filling up their airspace, and that's what we're seeing here. And when we do a bronchoscopy, we can actually see pink coming back to make a diagnosis. This is a very, depending upon the type of bleeding in the lung, this can be a life-threatening condition, and they frequently need very aggressive medications. So the group here thinks about this and sees these kind of children. And then we're to the unknown group. So there are people in this room who have unknown conditions. I'm going to show you, this is a patient that I care for. We all, and how many of you have unknown child disorders you see? You have one. Docs in the room? We all do. So we've made great progress, but we have to understand a lot more because we still look at families and say, I don't know, way too many times. And this is a patient that I've taken care of since 8 months of age, and she's 7 now. And her lungs CAT scan looks like this, and on her biopsy, she has both airway disease and she has air sac disease, and it's very difficult to know what she has, and it's very hard on families not to have a diagnosis. We have to do better for them. But they are part of our umbrella because that family has the same problems as a family that you do. Oxygen, school. What does this look like? So this is just to say that there are children who don't do as well, and some of them don't do as well when they're first born, and some of them die in the newborn period. We have a child looking for a parent. Okay. We all recognize that syndrome. So one of the things we found is that there are different types of risk factors for dying from your disease. And that's one of the things we have to understand. So this is one of the major risk factors, but we also have to understand, do you have chronic lung disease, and what does this look like for your lifespan? And you all ask us these questions. We say, I don't know, way too much. So that brings us to the big umbrella of the Child Foundation. Okay, so why did we decide to form this foundation with this big umbrella? Because certainly you can see the CF Foundation as just one disease, and you go to the network, you see, the internet, you see one disease, and you know, there's rationale for doing that. But it became our bias that these children presented similarly to the physicians. To isolate one off from the other, how are you going to educate people about that? So we thought about how we're going to educate, how we're going to define a diagnosis from kind of a clinical. And 2, though they have different diagnoses, they have a common family experience. Oxygen, school. What are you going to tell the neighbors? People are tripping over the oxygen. I can't grow. G-tube, reflux. You just all demonstrate it. So together, the families are powerful in how you can support each other. And we see usually physicians who take care of this kind of disease, these kind of disorders, child disorders, they do that. They don't tend to be as much the asthma doctors or the CF doctors because they're pretty busy taking care of these. And these kids, people who are taking care of CF and asthma say, oh, you got one of those child things. You better go see Dr. Young. or because it really, we keep up, we're having to think about this, and it's not, oh, you have CF and asthma, and we kind of know how to do that. So there are very specific groups of physicians to do that. So for the physician to group to say, okay, now we've got an organization for surfactant and an organization for, how could we go to all those meetings? Couldn't happen very well. Plus, our bias is there would be similar discovery pathways that could help us understand the other, and so that we were stronger together organizationally, because pediatrics is a minority population. We know that about funding for research and grants. And if you're in a hospital network or a healthcare network, pediatrics is a minority population, and we're stronger together. We don't need to be splitting apart. We're not that strong. So we're stronger together for organization, fundraising, and resources to move this forward for all of our children. It's pediatric focused. There are very few organizations that are like this, that are pediatric focused on pediatric lung disease or even other types of organs. So this is a very unique organization. And together, we need to partner with their adult colleagues and others. So these were some of the thoughts behind forming the foundation the way we did. I think it's important to understand that as you hear from other groups. And so the challenge of the foundation is how to have a big umbrella, but how to be able to provide resources to research all the different conditions. We'll handle that. But we got to be together in the total mission. So the Child Foundation, I don't need to show you this. We're very proud of this. We have someone from Spain here sent from, how do you say that? There you go. Who wants to repeat that? But I think she's a testament to what's happening, because what happened, it was really through you. The families found you on the Facebook, okay? And they started dragging their doctors in. And so it's through you that a lot of this is happening around the world. And actually in July, I'm going to China to talk on this. So it's really a national, international effort. We have to become like one big clinic to solve these problems. You've seen this, there's our centers, and the ones in the red have research consent and paid a little bit of money to have the database. I do that to try and get the others to move forward a little bit. But together, these centers are the centers of excellence, all the ones with the blue stars. And the centers of excellence really are establishing clinics to think about these children, because it isn't, to have one of these kids with chILD in another clinic without all these other resources isn't the right way. We've learned from our CF colleagues. And a chILD center of excellence should have these components. And if you're not at a center that can have this, maybe you should be there once a year at a center that can provide this so you have access to these thoughts once a year. And so our network is really moving forward. We have an acronym that people think we misspelled, and we didn't misspell it, but it's children, because it's the research network. I've told you it's multidisciplinary. We're trying to set standards and publish them so other doctors around the world, even if they're not in our network, know what to do and who to call in our centers. We're launching a web-based database that I'll show you that is very robust and, in fact, has a family part in the front end where you can track your child's stuff. It's very exciting what the foundation has supported. And now we have to get grants and get to clinical trials to do better and really begin to understand the mechanisms of these diseases, the genetics, what the proteins do, what the stem cells do, and drug screening programs. And our exciting scientific meeting you're about to hear about looked at these things. We brought scientists in because that's how we do better, is through research. So we're moving care, we're providing care, but we've got to get research to move care better. The database. You guys have to help us with the database, everybody in this room, because our brains are owned. Dr. Fan, I agree with everything everybody says of Dr. Fan. But that brain may someday retire. I'm going to try not to let it retire. No, it's not already retired. And I'm going to try not to let it retire. And it is really good. But